during the open discussion session, of course, and the facilitator for the day will come back to you. All right, so welcome. I would like to welcome you all on behalf of the partners that we have today for this panel discussion: the Public Services International, the Public Health Resource Network, the Swasthya Abhiyan, and the WHO. This panel discussion is a part of is an ongoing celebration of the World Health Day, and as you all know, the theme for this year is building a fairer and healthier world for everyone. And when we listen to this, we know that it cannot come true without having a look at the large health workforce that we have. And within that health workforce, the nursing cadre, which definitely plays a very important role in terms of primary healthcare, as well as is the biggest workforce in secondary and tertiary care settings in the country as elsewhere in the world. And this panel discussion fits right in there, where we will basically be talking about the equity in nursing work. And as always, the WHO is committed to this cause. 2020 was, as you all know, the year of the nurse and midwife. And as part of it, the very well received report on the state of world nursing is already there in public domain, and is a very important part of the discourse on empowering nurses and improving their working conditions and so on and so forth. 2021, again, as you know, is the year of the health and care workers. So the commitment is there right at the highest level, not just commitment, there's a huge amount of advocacy being done by WHO and other UN partners. And not only at the higher level, but even if you look at the ground level, there are many pieces of work. Say, for example, there are modules being developed in partnership with the nursing division of the Ministry of Health and Family Welfare on how to promote mental health among healthcare providers. And definitely nurses also form a big chunk of that. So we then quickly jump straight away to the agenda for the day. And in the first session, we have, in fact, two key presentations on some of the related research work that has been carried out in the past 1 year. The first speaker today will be Susanna Barria. She is from the PSI, and she's been involved with trade union movement for a decade and more. And she currently works with the Global Trade Union Federation, PSI, including on issues affecting healthcare workers. She will be joined by Ipsha Chand. She is a public health researcher, currently working with the Public Health Resource Network. And the second presentation will be by Sweta Marathe. She is a health systems researcher with SATHI, the Support for Advocacy and Training to Health Initiatives. This is an NGO which is based in Pune, Maharashtra. And her research work largely focuses on corporatization of private healthcare sector in India and different aspects of public health. Well, ladies, I hand over the floor to you. Thank you.
Thank you, Dilip sir. Before moving to the actual presentation, I would like to make a few introductory remarks about the study. The study was undertaken at the request of a nurses association. The study core group also included a registered nurse who played an important role in shaping the study. This webinar is only a part of an ongoing conversation on nurses issue, which follows from another webinar which was organized in September 2020. And we also have in mind dissemination of the study report through various meetings with nurses union and associations. Next slide, please. So studies on nursing in the Indian subcontinent mostly focus on issues such as distribution of workforce, migration, professional hierarchy, gender, and so on. But there is lack of systematic studies that document the status, work, or working condition of nurses within private sector. To fill this gap, which was also highlighted by the Nurses Association, in the existing knowledge, which was sorry. So to fill this knowledge gap, an exploratory study was conducted jointly by Public Service International, Public Health Resource Network, Jan Swasthya Abhiyan, and WHO during March 2020 to October 2020. The objective of the study was to center stage the perspective and voices of nurses on various issues that affect and shape their work and working condition. Now, this particular study employed the technique of qualitative in-depth interviews and FGD with nurses working within private sector hospitals in Delhi. And also key informant interviews were conducted besides literature review. Major challenges faced by the study group was recruiting participants, since many nurses were either terminated by their employers, had resigned from their job, or left for their home state during pandemic. Another barrier that was faced was apprehension of nurses of being victimized if they participate in the study. Our study findings suggest that there are several daunting inequities faced by nurses within their workplace. And we have organized the findings into 4 axes of inequity, which will be dealt in the following slides. So our study participants highlighted the very fact that there is lack of recognition of nurses as professionals having high level of training and experience by their private sector employers. This is also reflected in the extremely low level of salaries which is offered to nurses, both in absolute terms as well as in comparison to their counterparts working in the public sector. The minimum salary that is offered to nurses start from less than 15,000 for fresh recruits, which is almost 1/3 of the salary that a nurse working in the public sector would get. Now, remuneration of these nurses are even higher than the Delhi minimum wage, which is around 19,500, even for clerical worker having a graduate degree. The other inequities highlighted by our participants were higher incidence of job insecurity, irrespective of the skill, knowledge, or work experience of a nurse. Our participants also spoke about lower employment benefits, inadequate social security, and their and low ability to access um, the sanctioned leaves. Beside all these factors, that the participants perceived that the nature of their work was less satisfactory, also due to lack of promotional avenues and the growth opportunities offered. The study findings also bring out the various processes that contribute to the marginalization of nurses, also rooted within professional hierarchies. And these hierarchies can be seen as interdisciplinary hierarchies between nurse, physicians, or other technicians. And this hierarchy is nurtured by the assumption that it is the doctor who brings money to the table. The nurses have limited or no participation in the decision-making process. And one of the reasons highlighted for this discrimination by our respondents was failure of recognizing and acknowledging the capability of nurses as trained and skilled health staff. Nurses also bear high workload, which includes nursing as well as non-nursing roles entrusted by their employees, which ultimately affect their efficiency to perform their clinical roles. And then it is the nurses who are held accountable even for non-nursing errors, and which have negative implication on nurses, such as salary deduction or even cancellation of leaves. Coming to intradisciplinary hierarchies between nurses and their nurse colleagues, the study findings show that the gap between nurses of higher rank, especially superintendents and managers, and majority of the nurses in terms of remuneration, entitlement, and power remains extremely high. The management protects this status quo of existing hierarchy by replacing the very senior nurses with fresh recruits at a lower salaries. Another mechanism deployed by the management is to keep the promotional avenues very low so that very few nurses can rise in the ranks of supervisory or management position to participate in the decision-making process, both for patients as well as for nurses. Now, this hierarchy is systematically nurtured by the management. Hence, at the time of need, the nurses fail to gather support even for genuine issues. These hierarchies were found to be used as means to sustain systematic disempowering of nurses. And the study also found evidence that nurses are subjected to insulting behavior, public humiliation, and harassment manifested in various forms, even for minor mistakes. Here, I would like to call my colleague Susanna to take us through the presentation.
Thank you very much, Ipsha. And I'll continue from where you left it in looking at the axis of inequality. And the third one that we wanted to highlight is that of the formality and informality and nurses that are facing informal working conditions. And we found that that is really widespread, with fixed term contracts for a period not exceeding 2 years being the norm, except for very senior positions. And we found that an upstream factor that needs to be considered is the nature of nursing education, because we found that the poor quality of private nursing education and pressure to repay loans had led many times for nurses to compromise on employment and on pay. Fixed-term contracts make it very easy for management to fire nurses, and as a result, few dare to ask for their entitlements. And the majority are deprived of health insurance, pension, maternity benefits, increments, gratuity, even when these entitlements are provided by the law. Emboldened by the precarity of nurses' employment, we found that management hospitals are also reluctant to acknowledge the role of nurses' organizations as interlocutors in bipartite collective bargaining. And as a result, nurses' organizations have found that they don't have other resorts but to take industrial action, more confrontational forms of industrial action to achieve negotiations and ensure that their issues are heard and resolved. We also found that the issues raised by nurses include demands that have a bearing on quality of care, such as, for instance, increasing nurse-to-patient ratios, which we found to be well below national norms, or adequate implementation of infection control protocols during COVID. Yet their informal condition makes their voice easily dismissed, whatever the demands are. The fourth axis of inequality is that of gender, and other studies have pointed to nursing being devalued as a profession linked to it being a female-dominated occupation. Yet what we found is that health facilities are largely gender-insensitive workplaces. This is in terms of basic amenities such as washrooms, changing rooms, restrooms, daycare, nursing station for female nurse employees. It is also true in terms of the ability to avail maternity benefits, which policies often remain on paper rather than translate into practice. We found that nurses that are eligible were faced with sometimes harassment, additional work burden, posting in difficult words, humiliation as a strategy nurses felt to make them leave, or sometimes they were also dismissed, for instance, under the pretext of unsatisfactory performance. Further, despite that the law provides that health facilities, like other workplaces, should have an adequate CASH, a Committee Against Sexual Harassment at the Workplace, such committees were either inexistent, inadequate, or at best dysfunctional. Importantly, linked to the earlier finding with regard to the nature of social dialogue, we also found that the more confrontational nature of social dialogue in private healthcare creates an additional barrier for women to play a role in their own nursing organizations. Next, please. This abysmal state of affairs is unfortunately not new. The dissatisfaction with nurses' working conditions led to a petition in the Supreme Court in 2011 and a judgment in 2016 that did acknowledge the need to improve these working conditions and the working conditions of healthcare workers in the private sector. Subsequently, the Jagdish Prasad Committee recommended to ensure graded pay parity between the private and the public sector, as well as parity in working conditions. It also recommended enacting legislation to specifically regulate the salary and other working conditions in the private sector. Following this, in 2018, the Delhi government had an order directing facilities to comply, though it didn't initiate the legislative process or has not really ensured implementation of the order. At this point, it's important to point out that while a majority of labor laws do cover nurses, and this is due to the fact that their salaries are so low that it brings them within the threshold for legal coverage by national level laws. These minimum standards are insufficient to adequately regulate the nursing profession, both with regard to working conditions as well as with regard to salaries for nursing professionals. Yet the study points not only to the reluctance of private sector to abide by court and government orders to improve working conditions, but even worse, it points to a widespread lack of adherence to the existing laws and regulations, as well as the government's lack of acknowledgement of its own role in ensuring implementation of existing laws and regulations. To conclude, other important findings are also that the low salary, poor working conditions, low social status and dignity were found to be contributing to out-migration of nurses. Conversely, improvement of these conditions and more opportunities in the public sector were highlighted as factors that could prevent nurses from going out of the country. Our findings also point to the positive impact of collectivization among nurses, as it gives them the confidence to take their problems to management. And as an illustration of this, it is the continuous and persistent effort of nurses themselves through public campaigns, industrial actions by their associations and unions that led to the petition of the Supreme Court and to the landmark judgment of 2016. And we have someone from the Trained Nurses Association of India also on the panel today. However, unions and associations are actively discouraged in health facilities. We found systematic victimization of those who attempt to create awareness and organize unions. This is also evidence in the recent cap on hiring male nurses, which in some cases is capped at 10% of the workforce being male nurses. And this was also highlighted as being because male nurses are seen as being more active in union organizing. A point about the pandemic, we found that pre-existing employment and working conditions deepened the inequalities and deepened the challenges faced by nurses during the pandemic. And we actually have multiple testimonies of the avoidable difficulties that nurses faced at a time where so many sacrifices were expected from them. So in summary, inadequate regulation, lack of political will, in combination with the imperative to maximize profits by keeping the cost of human resources down in a sector that is largely human resource dependent, is enabling a continuity of abysmal conditions for the nursing cadre. And the ray of hope lies in organized solidarities among nurses and from communities and the public they dedicatedly serve. Thank you very much.
Thank you. Thank you, Ipsha and Susanna, very well presented. And the whole report of titled Nurses Speak is something that is being edited for language and being designed. It should be coming out very soon, and I suggest that all of you should get your hands on a copy of that. That will be a publication from WHO and with the partners. And we had limitations for this short presentation, but there are very, very interesting anecdotes which come out in that particular study. You can quite literally feel the voices that come out from the nurses, So I suggest that you do go through the report once it comes out. And my special thanks to the study partners. 2020 was a very difficult year, and for all of us, including the nurses, maybe more for the nurses, but we were still able to complete this study. And I'm also equally looking forward to getting this report published as early as possible. Thank you, both of you. I think then we move on to the next presentation.
Yes.
Shweta.
Yeah. Shall I start?
Yes, please.
I think slide is not properly visible yet.
It is not.
Yeah.
Just give me a second.
Better. Much better. Thank you.
Yeah. Okay. I'll start. Yeah. Thanks, Dr. Dilip. I would thank organizers firstly for giving me this opportunity to share COVID experiences of nurses from the state of Maharashtra. I thank Susanna and Ipsha also for their insightful presentation. And I would like to mention that to a large extent, Maharashtra case also shares similar experiences. So in this presentation, I will share key findings from the Sathi study on understanding challenges faced by nurses during COVID-19 epidemic in Maharashtra. So we undertook this study with the two key objectives. One is to understand challenges faced by nurses working in public and private healthcare settings from urban and rural parts of Maharashtra. And second is to document demands raised by nurses, their unions, and understand how respective authorities, systems, managements have responded to their demands. This was a cross-sectional study, and we conducted semi-quantitative online survey with 367 respondents, and we also conducted 5 in-depth qualitative interviews with some of the respondents. So before we look at findings, this is just to briefly give you, next slide please. Yeah, before we look at the findings, this is just to give you an idea about profile of respondents. So as you can see, 88 respondents were women, 23% respondents were from private sector, and 47% were from rural areas of Maharashtra. Next slide. Now coming to the key findings of the study. The first challenge is workload on nurses during COVID pandemic. We found that 58% nurses has extended duty hours with more than 8 hours per day, and 57% nurses has very low patient nurse to patient ratio. In some cases, it was even 1:40 or to 80. It was the case in case of especially case of municipal and medical college hospitals from metro cities like Mumbai and Pune. This is obviously linked with long pending issue of vacant post of nurses, and this situation we can say that it also disregards ILO's decent working time agenda with appropriate staffing. We can see here the quote by nurses representative. In rural situation, the situation is quite worst, especially in government hospitals, and in metro cities, situations seem to be better because at least some level of recruitment did take place there in month of April, May last year, but things did not move at all with government hospitals from rural areas. Next slide. Then next is about denying granting regular and COVID specific leaves to nurses. 65% nurses reported about not getting leave sanction. Of course, this goes back to the issue which we discussed in the previous slide about vacant post and the workload. Then COVID specific leaves to COVID positive nurses. This was also largely granted only in public hospital, but this wasn't followed in private hospitals. Instead, their leaves were deducted from annually entitled leaves. Then salary deductions and delays. This issue was also nearly faced by half of the nurses during COVID. Delayed salaries was also experienced by several nurses from public sector, and it was quite severely faced by contractual nurses. Private sector nurses too faced the crunch of salary. Nurses from some small private hospitals as well as newly appointed contractual nurses from big corporate hospitals were forced to go on leave or work only for 15 days and were paid 50% of the salary. We can see here the quote from nurse who is working in big charitable hospital who shared that management refused to pay them annual appraisal in the name of loss that hospital have faced during COVID epidemic. Some nurses also talked about poor salary scale in private hospital, which again I think goes back to the private hospitals' reluctance to follow Supreme Court's recommendation of increasing wages. Next slide. Then another critical issue is to ensure occupational health and safety of nurses. As per Supreme Court judgment 2017, the right to safe working environment is part of fundamental right to a right to life. But 61% nurses reported about inadequate safety equipments, and the issue was quite severe in the initial months of the pandemic last year. But later on, situation improved, but issue of substandard quality of safety equipment still remained. And when we asked nurses about their feelings about they being recognized as COVID warriors, a nurse representative criticized it by saying that when health staff and patients are going through such a crisis and such a critical situation, there is no practical meaning to propaganda of COVID warriors. Now let us look at situation regarding pandemic specific provisions and facilities for COVID positive nurses. Only 28.5 of the total nurses reported that they received COVID allowances, except for public sector nurses who work in municipal hospitals from metro cities. No other public sector nurses received this allowance. Also, private sector nurses had to struggle a lot for this, and as a result, some private hospitals provided this allowances, but the amount was quite nominal and was not at par with the amount which was paid to municipal hospital nurses from public sector. Provision of healthcare facilities such as testing, treatment, and quarantine was also quite important for nurses in this period. Majority of nurses reported that they had these all facilities from the hospital they worked with, but situation wasn't so rosy. Nurses had to struggle a lot to obtain these facilities. Most public hospitals from urban areas accepted nurses' demand and made these arrangements. Some municipal hospitals also allotted dedicated COVID ward for them. Of course, this was done after a lot of struggle. One nurse shared that regarding quarantine facility, they experienced discriminatory approach. Priority was given to doctors. Also, hotels were assigned for doctors, while dormitories or wedding halls were assigned to nurses. I think this illustrates inequity in practice and underscores the need for equitable approach towards nurses. Then, in case of private sector nurses, some hospitals charged them for COVID testing, and the cost was deducted from their salary at the month end. Also, private sector nurses demanded for range of facilities and provisions which are specific to COVID, but private hospitals never provided facilities for quarantine or allotted dedicated COVID ward for nurses. This is out of nurses who participate in the study. So, this finding belongs to all of them. Next slide. Another serious issue faced by nurses during COVID is pressure from hospital management on raising demands for basic provisions. 23% nurses share that they faced such pressures from respective managements. If we see the breakup of this, 19% nurses from public sector and 57% nurses from private sector reported about such pressures. Private sector nurses were mainly pressurized by threatening them with salary deductions, loss of employment through direct termination or forced resignations. A small proportion of private sector nurses also reported that male bouncers being sent to their hostels to threaten them. According to UNA representative, such bullying is not so uncommon, and I think that is quite worrisome. Some private sector nurses also reported that they were scared to put forth their demands. Head nurse or matron used to keep watch on them, and a strict warning was issued to them that they should not share any information about nurses' issue with any outsider. Next slide. Yeah. So coming to the last slide now. So from this study and the analysis, it can be said that there are certain issues which are common to public and private sector both. Uh, Regarding shortage and poor quality of PPE, workload, not getting leaves during COVID, or delayed payments and deduction of payments. While there are certain issues such as pressure from hospital management or non-provision of basic facilities, I think there was a significant difference in both these settings, and it can be said that this difference is emblematic of specific features of each of these sectors. Public health system nurses were often overworked, but they were relatively better placed as far as facilities are concerned as compared to private sector nurses. Within public sector, if we see, nurses from urban areas were better placed, while nurses from rural areas faced dual challenge of being overworked and deprived of basic facilities as well. Contractual nurses in public health system also suffered quite badly with majorly delayed payments, and they do not even have proper space to raise their issues. So their situation was quite pitiful. While private sector nurses seem to remain devoid of specific COVID specific facilities, and they faced much more uncertainty and pressure regarding employment condition, which points to precarious conditions and precarity among them. Overall, I would say study reveals violation of fundamental rights, violation of health workers' rights on various fronts, which ultimately highlights the need for fairer, healthier, and equitable working conditions for nurses. I'll stop here. Next slide. Yeah, I'll stop here due to time limit. I will not get into recommendations because there is a long list of recommendations ranging from filling vacant post of leadership positions in nurses to regulation of private sector. Dr. Swati Rane, who is a panelist out here, she was part of our study and she would probably talk about those when her term would cut. So I'll stop here. Thank you very much.
Thank you, Shweta. This indeed was a very beautiful presentation that you made. And I was just looking at, because the earlier one was largely private sector, where the fact that, salaries were more in the public sector and all made us all think that probably the grass is far greener on the other side, but it doesn't seem to be so. Public sector nurses also have their own set of problems. And one common thing that I see between the two studies is, well, I mean, COVID-19, yes, we all know, but the sample sizes may be small in terms of numbers when you compare to the hundreds of thousands of nurses across this country. But the findings are very easy to extrapolate, both in the private sector and public sector all across the country. And many people who are nurses, who have been in the clinical field, doctors included, and many patients who access healthcare facilities, public or private, these findings will echo through their minds, and you will find a lot of resonance among various sections of the society. Thank you once again. And so we now move on to the panel discussion. Thank you, Sweta. So we have a very interesting mix of panelists today lined up for all of you. I would just like to, lay out some more micro ground rules, so to say. For the panelists, what we are expecting is that we would like them to do probably a little bit of deep dive on issues that really they feel, from the findings that we have seen so far. Secondly, we would also like to start off with one leading question, which is related to your area of work or your organization, the organization that you represent, and also briefly touch upon that particular question as well. And you will have an intervention time of about 5 minutes to say. So I suggest the panelists to switch on their cameras, and once I call out their names, a slight wave of the hand will be easier so that for people to identify with you. First of all, let me introduce Christiane Wisco from the ILO. She's a senior specialist for the health sector in the International Labour Organization in Geneva. She and her team, they work on advancing improvements of employment and working conditions and strengthening social dialogue in the health sector, and so as to assist the Promotion of Nursing Personnel Convention 1977, and within brackets number 149. All right, next on the panel, we have Anna Torrente from the same organization, the ILO. She is the head of Employment Policy and Tripartite Governance Unit in the International Labor Standards Department. Anna, are you there? Okay, maybe I can see her, but she's there. Okay, fine.
Yes,
Right.
you can see me?
Yes.
Okay.
Hi. All right. So, she and a team, they're currently working on the general survey on decent work for care economy workers in a changing economy. And this focuses on the application in law and practice of Nursing Personnel Convention and the Domestic Work Convention of 2011. And they look at situation of nurses, midwives, and the community health workers, as well as domestic workers. The survey will also focus on the COVID-19 impacts on these workers. So largely, the kind of work that we have done in these two studies on a smaller scale is being done at a much higher scale in the global scenario over there. We were supposed to be joined in by Dr. Sanjay Nagral, who's a surgeon in the Jaslok Hospital, Mumbai, but he had to go in for an emergency surgery. So probably at some point, if he's able to join or join at all, then we will hear from him as well. I would like to take some time to introduce you to Miss Evelyn Khanna. Evelyn, are you there?
Yes, she's there.
All right.
Yeah,
So,
yeah. Good
hi.
evening.
Good evening, Evelyn. Evelyn is the Secretary General of the Trained Nurses Association of India, the TNAI, which happens to be the oldest nursing association in India. And they're also a very prominent member of the Indian Nursing Council. The next panelist that I would like to introduce is Swati Rane. Swati, hi. Right, so Swati is an independent nurse researcher with a focus on impacts of nursing work environment, and she has been actively associated with raising the issues and concerns around nursing work and public health. And we just heard Sweta saying that Swati was a part of the study that was carried out in Maharashtra as well. All right, so those are the panelists for you for today. And let us first of all hear from Christian. And Christian, the question that I have for you, also for you to reflect, is because we all have heard of very difficult employment and working conditions of nurses in Delhi, and probably a similar situation exists in the other big state, the economic capital of India, that is in Maharashtra. So what are your reflections based on your expertise on such issues which exist globally? Christine, I hand over the floor to you. Please go ahead. Thank you.
Thank you very much, Dr. Dilip, and thank you for the organizers, and congratulations to the researchers for the two very informative studies. And I would agree that what you said, Dr. Dilip, that even if those are small or relatively small sample sizes, the issues raised, well, to me, they were no surprise, because we read them over and over again. We hear them in lots of studies across the world. And my dear colleague, Anna, whom I see here after weeks for the first time. So we'll talk to the Nursing Personnel Convention later, but I think it is important to know that the discussions leading to the adoption of the Nursing Personnel Convention in the mid-70s, like starting in 1973, these preliminary discussions already discussed those issues. So we are not faced with new issues here, and we have to ask the question, why is there so slow progress made on the issues that are known for over 40 years, nearly half a century, and they haven't changed? So the question is really what's going on, that nothing. Well, there are improvements, let's be honest, there are improvements, but in general, the issues remain the same. When I read and thank you for sharing the executive summary of the first study, I very much appreciated the second study because it compared also public and private sectors. I think that is very important. Because when I look across countries, there are countries where the working conditions in the private sector are much worse than in the public sector. And there are countries where the working conditions in the public sector are so bad that the nursing and other health workers work to the private sector. And the public health systems have problems to retain the health workers. You have to stop me if I pass the 5 minutes. Huh? I forgot to look onto the clock.
I'll sound you.
Okay, because this is something we could talk about hours, and I'm happy we have enough time to do so. I think, let me put it a bit provocative and saying that the nursing, and you rightly said, the nursing personnel, the nursing workforce, the nursing personnel is highly gendered. It's like between 80 and 90% of the nursing workforce is female. And what comes out from the studies is also these interprofessional hierarchies. And I think when Florence Nightingale started some 200 years ago, her battle for the recognition and for the professionalization of nurses, I think this battle is still ongoing, though big advancements have been made. But there is also, this is a question of mindset. So in many countries or health systems, we still find this attitude of, a nurse being a servant to a medical doctor. I'm very polemic here, I'm sorry. While we know that the nursing workforce is the biggest single occupational group in the health sector. Without the nurses, nothing goes. So, I mean, come on, yes, we need medical doctors, we need nurses. So they are as important as every other health worker. I always think, or I'm convinced that health work and health care is teamwork. And every person, every occupation has its particular role, responsibility, competency, advantages, and knows how to go about, and caring for a patient is a profession. It's a very complex task, and I know from own experience, it's very, very complex, and it needs a lot of skills and training. So I promise to be a bit provocative. I think that we have to do here with a double penalty, and that is the nursing not being recognized as fully professional, as on a level playing field at a height of eye to eye, from profession to profession. What I hear from the studies, and there are other examples where it works very well. The other penalty is being female. And we know that women are very much discriminated against in the whole world of work. But we see that care work, especially care work, has been historically and still is being systematically undervalued due to these gender dynamics. I mean, caring for a person. If a woman can do that, that can't be difficult, or so. this is, you know, the case of female work not being recognized as work. And we see a lot of unpaid care work taking place in families. So families would not function without this care work. But in the professional field, we see this being translated into what was raised by the studies also as the discrimination of female employees being women, but also being nurses. And I want to express my deep respect for this profession, for every health worker who is working to promote the health and to save lives. Yes, and this is my final sentence. I really think they deserve the respect from everybody, and they should be proud, and everybody should be proud to have a nurse around. They should be proud and should be recognized according to what they do. And without them, the health systems wouldn't work. This is very important. Thank you very much.
Thank you, Christian. And we'll come back to you again after the first round for a wrap up of about a few minutes with all the panelists. And thank you for the fact, for pointing out the fact, and it couldn't have come from a better individual, that the issues are actually global. They remain common globally, and just depends on which side of the fence you're on, the public side or the private sector, but they exist. And this particular thing about gender is, this is completely true. We just finished a study in India. One of the data source that we had examined was something called a NSSO for the year 2019. And we've just published a paper in the BMC HRH journal as well, and where we talk about huge dropouts of the health workforce from the active health workforce, and the majority of them are females. So point well taken. And thank you so much and as you said, we can keep going on and on because this is such an interesting topic for all of us. All right, so can I then just call upon the next panelist? Right, Anna, but to start with, I also have a question for you. And here it goes. The ILO, as you say, is, reviewing currently the ILO Nursing Personnel Convention on 149 and the Nursing Personnel Recommendations 157. So in relevance to what we've just heard, of course, you can dwell on some of the findings, but in light of the findings that we have, can you tell us a little more on this two very interesting things that you're working on? Thank you. Over to you, Anna.
Okay, thank you. I'll try to talk a little fast because, as Christian said, there's so much to talk about with this convention and with the general survey. But first of all, thank you very much, Dr. Dilip, for the invitation, and to the organizers, and for sharing these elements, these studies, and the results, the findings that can certainly be referenced already in some of the areas that we're addressing in the general survey. So first of all, as you noted, the general survey is going to talk about, it's entitled Decent Work for Care Economy Workers in a Changing Economy. So the idea is that the focus is on Convention 149, but we're also going to look at domestic work and other forms that care work takes. For example, sometimes where live-in domestic workers are being asked to take on tasks that would normally be provided by nursing assistants. So we're sort of looking at the overall, the range of care work. And we talk about changing economy because we're also looking at, well, how have transformations in the world of work affected the way that healthcare workers, including nursing personnel, practice, the structure of work, maybe the implications of telemedicine. So we're looking at this. The general survey was requested by our governing body in 2018. And the process, just very briefly, of a general survey is that the Committee of Experts, which is our supervisory body, will look at how a convention, the principles of a convention, are being applied in law and in practice. So, there may be, as you've already referred to in the study, a court decision, for example, because that's one form, right, case law, but is it being applied in practice? So we're basically, the ILO sends out a comprehensive questionnaire, which we prepared, to all of the countries, and it's also supposed to be shared with the social partners, the employers and workers organizations. For example, for this particular sector, it would be, the healthcare organizations, the associations like the International Council of Nurses and nursing associations in the country, to determine what is happening, what is the situation of care workers, particularly nursing personnel, because we're looking at the convention, the application in the country, and what are prospects of ratification of this convention, what are the challenges in applying it. So we basically will send out this, we've sent out this questionnaire, and countries have submitted their reports. India, in fact, we have just received their report, a bit behind the deadline, so they had requested some additional time, and we have not yet had a chance to review all of it, partly because there were a number of annexes about salary scales, remuneration, and other issues that were not attached. So we're chasing that up, but we have received the report from India. In the process of this, sending out this questionnaire and gathering the information to be examined in the general survey, we are taking into account first the government reports, the comments, and then also there is a deadline at the end of June for comments that we may receive from the workers and employers organizations. So what we are also encouraging is for the organizations in the sector to provide us with information of where they see problems, where they see challenges. And I mentioned the fact that this was requested in 2018. Normally, the general survey would have been undertaken in 2020, but with COVID, everything was postponed by a year, and there has been an additional request from the ILO to governments and to the social partners for information about how COVID and the consequences of COVID have impacted on care workers. And so we are going to be adding, or we have added, a significant component to the general survey, taking account of some of the factors that you already mentioned today, like the increased stress on nurses and midwives. We've seen information on the mental health impacts, post-traumatic stress disorder, depression, anxiety. And we've also seen, you've talked about discrimination. We've also seen stigmatization, not just because of the gender aspect, which you've already discussed, and I don't want to take too much time, so I won't dwell on that. We are looking at the gender dimension very carefully in all aspects of addressing the convention, but also we're looking at stigmatization due to COVID, where patients either discriminate or there is violence or against nurses or nursing personnel or health workers due to their involvement in treating patients that have been infected. As well as, of course, all of the challenges involved with lack of facilities, lack of testing, lack of PPE. And so we're taking that dimension into account. In light of the information that the study compiled, which to echo Christiane is really not surprising. We see this in reports that we've been receiving from countries, all the challenges in terms of working conditions, in terms of discrimination, in terms of lack of career progression, lack of access to adequate training, lack of involvement or participation of nurses in determining, for example, the training that they want to receive, or many other aspects of their work. You know, we're looking at all of these aspects. One thing that I should mention also is that going into the convention itself, we're going to be looking at Convention 149. First of all, has not been ratified by India. It's been ratified by 41 countries. Even though a country has not ratified a convention, it can be held to apply certain principles. For example, I know I have very little time, but I just want to bring to your attention, for example, the preamble of the convention that we're going to be looking at. Because we've heard in the course of doing this work, we've heard a lot about discrimination between male and female nurses, for example, in terms of empowerment, in terms of remuneration, access to career progression opportunities. But the convention itself doesn't mention it. So we get asked the question, well, why doesn't the convention talk about discrimination? Well, the preamble of the convention, first of all, this convention was supported and it was developed with collaboration with WHO. And one of its objectives was to recognize the value, the importance of nurses in healthcare systems to the public health, because as Christiane pointed out, without nurses, nothing runs. And it was a call for recognition of the status of nurses, of their education, of their training, of the contribution that they make to the health of the public. And it also, the convention also says that nursing personnel are covered by many international labor conventions and recommendations that lay down general standards concerning employment and conditions of work, such as instruments on discrimination, freedom of association and the right to bargain collectively, hours of work, holidays with pay, paid educational leave, social security, maternity protection, and the protection of workers' health. So while India has not ratified Convention 149 and is not bound by certain of the specific provisions, it is bound by the fundamental conventions like the Discrimination, Equal Pay, Equal Remuneration Convention that it has ratified, but even the other fundamental rights conventions that it has not ratified. These are referred to as fundamental principles and rights at work. So that even if India has not ratified the two fundamental human rights conventions on collective bargaining and on freedom of association, India is considered to be as bound to respect the principles of collective bargaining. And I thought, since we've talked about the weak bargaining power of nurses, that was something that was important to mention. And what the
Anna, can we come back to you in your next round? We just need to move on.
Sure, I knew that it was too much for 5 minutes.
Would you like to make a closing statement for the time being, or should?
Yes, just to very briefly to say that under the convention, one of the things we're looking at is that it calls for equal working conditions for nurses, for fair working conditions in a number of areas, such as hours of work, sick leave, maternity leave, and we can come back to that, but that nursing personnel should be accorded the same or at least equivalent working conditions to other workers in the country, and that it also calls for a policy that will provide for employment and training opportunities for nurses and midwives that are designed to attract nurses to the profession and retain them, because you've already mentioned the issue of shortages of nurses, or nurses, especially during this very extremely difficult time of the pandemic, dropping out of the profession. So that is a very important element of the convention, is that it seeks to attract and keep nurses in the profession where they're sorely, sorely needed. So with that, I'll stop here. Thank you.
Thank you, Anna, and those are excellent updates, and I hope things with Indian approval gets sorted out very soon. Both of you, there has been a lot of reactions to your thoughts in the chat box, and some of them directly correspond to what you just mentioned in your initial introduction. So I suggest that you please have a look, so that when the second round comes, you may be able to address a few of them. All right, so without any further delays, let me move on to the next panelist that we have, and that's Evelyn Khanna we have for you next. And Evelyn, before we start, I just have a small question for you. It's the oldest Nurses Association, the TNAI, and in fact, also happens to be one of the petitioners in the Supreme Court case, which led to the Jagdish Patel committee report. And this is the one that Susanna spoke about, and Ipsha, they spoke about in their presentation, if you remember. So just a very brief thought. What thoughts do you have on the findings which are presented in the study, and what do you think are the potential bottlenecks we might have while we try to push for recommendations and how to implement them, which have come out in this report? Over to you, ma'am. Thank you.
Yeah, thank you. Thank you so much for this great opportunity you have given to us, and a very good evening to all. And Professor Dr. Roy K. George supposed to be here, but he has due to prayer commitment, and he could not get in. I pitched in for this event. I'm honored and privileged to be part of it, to be as a panelist on this great panel discussion on mainly the very interesting and topic on building a fairer, healthier world, Equity Nursing Week, and special thanks to the organizer for organizing this panel discussion. Just give me a moment to share the screen, please. Can you give a permission to share the screen, please?
Yeah. Just give a moment. Somebody will work on it.
Done?
Susanna, can somebody just pass on the rights to her, please?
It's only Saiful who can do it.
Only Saiful can do it. Okay, Saiful, I don't know. I think. Okay. Let me try to get this done. But will you, in the meantime, you can just give your initial thoughts. Let me just work on this. Okay. Thank you.
Yeah.
Please start, Mrs. Evelyn. Please go ahead with the screen share.
Yeah.
Thank you.
It is done?
We won't be able to do it right now, so you might have to just go ahead.
Okay.
Thank you.
As you all aware that TNA is a 113-year young association. It is a non-profit, non-sectoral, non-political and non-religious organization, and working solely for the benefit and advancement of nurses. Currently, we have more than 4 lakhs members, and members are from clinical nursing service, nursing education, research, nursing administration and public health, and member also from the central government and state government institution, private, corporate and mission hospital and voluntary and corporate organization. And one of the major aims or objective of association is to uphold in every way the dignity and honor of the nursing profession. Another most important is to advance professional, educational, and socio-economic and general welfare of the nurses. This has been our motto since 1908. And 1937, they adopted the Nurses Charter mainly to represent the highest health policy making body to improve the working condition and welfare of the nurses, and to prepare and be constantly be preparing and submitting the recommendation for decisions and policy making. And again, one of the major milestone of TNA is instrumental in establishing the high power committee on nursing and nursing profession, which was appointed by the government of India in 1987. And the recommendation, major recommendation, still it is not fulfilled, majority of the recommendation. Number one, we recommended that working condition of nursing personnel. Under that, the no uniformity on employment procedure and recruitment rules, no equal pay for equal work. And this is a cry of the entire nurses in India even today. And another recommendation which we made during the time, job description of all categories by the government of India is not a uniformity. And working hours and facilities, pay and allowances, promotional opportunities are not there. And career development is not properly. And accommodation facilities, transport, special incentives are not given. And there are a lot of occupational hazard which we nurses are facing. Other welfare measures are not heard. Number of manpower required is not at all up to the level of the recommendation. That was the reason the TNAI pitched in 2011, filed a case in the Supreme Court regarding the welfare of nurses on enhancing the salary structure and working condition of the nurses. In previous speakers and two presenters, they very well pointed out that what are the various areas the nurses has been suffering. And 2016, India Apex Court ordered the central government to set up a committee to investigate the working condition and salary structure of nurses working in private hospital. When we compare now the private and public hospital, public sectors are a little bit better than the private hospital. I think 1/5 or 1/4 of the salaries are lesser for the nurses, those who are working in the private hospital. In 2016, the committee has been formed under the chairmanship of Dr. Jagdish Prashad and DGHS, Minister of Health, and TNA is a member of the committee. I was present in the committee when we are making the recommendation, and this recommendations of the committee constitute in compliance of Honorable Apex Court judgment, and we have distributed, we have constantly, the TNA is sending this information to various state branches of India, because currently we have a 33 state branches under the umbrella of the TNAI, and almost every 2 to 3 months we have been constantly sending this recommendation to implement the various branches of, that means various state and UT branches of TNAI as well as in India. But what are the major, some of the initiative follow-up and initiative taken by the state government? In Mizoram, government has formed the committee to formulate the guidelines, but no information received so far. They only formed the committee. And Goa government has submitted the recommendation to the Under Secretary Health with the approval of the DHS and for the implementation. Till today, we have not heard anything from the Goa also. For government of Kerala, prepared a proposal of revision of minimum wages. Certain extent they have achieved, but still we need to work more than that. And TNA has once again filed a writ petition in 2017 in the Honorable Delhi High Court to adhere the recommendation. And Delhi High Court has given, that means the ministry has followed a little bit now. The Delhi government in majority, major private hospitals are giving, that means minimum wages 20,000, but still it is not happening into entire small or private hospitals in Delhi even. And that recent council, TNA council has again planned that, because the most of the states are not adhering the recommendations, are not giving the proper, that means here to us. And again, we are planning to file the case in every state branches, various branches or various state and as well as the union territory to fight against this battle. but we are waiting with the hope that definitely we will hum honge kamyab ek din, with all the that means support of our entire nurses in India. We will keep fighting and keep arguing, keep recommending and keep submitting. But it is very sad to know that, because even 2020 is the year of the nurse midwife. The World Health Organizations marked as the year of the nurse as a midwife on the eve of the 200th year of the Florence Nightingale. And even very well, the entire world knew very clearly that, because the nurses comprises the more than almost 59% of the healthcare system, and they are very well aware that, and that means without nurses, in the previous speaker, they said that without the nurses, we cannot move on. And the nurses are the fire, that means life wire of the health services. And we all know very clear, the whole, even the universe know that nurses are, when we, this is a very low cost, that means cost effective, when we empower the nurses, when you do the things for the nurses, and when we nurture the nurses can nurture the entire universe. And with this, I'll just conclude. If they have any questions, definitely I'm here to answer. And because why the nurses, the TNA has taken up the cause, because since 1908, even the 1989, the high power committee recommendations given, that means even still the recommendations are not filled. There is no, very well, there is no proper working condition for the nurses. There is no proper salary structure for the nurses. There is no proper career growth or career development, continuous professional development is not there in the agenda, main agenda of our health system. Because main thing is why is we are unable to make it, because health is a state subject, and every state they have their own priority, and it's a political will. And still we are finding, these are the reasons we are finding it really hard to get the rights of our nurses.
Thank you so much. Thank you. And also thank you so much for almost being there with time frame. Thank you so much, but very interesting thoughts. And it's about, what you do is about trying to facilitate where it normally boils down to policy versus the implementation. So our sincere wishes that you keep doing good work, and best wishes with you as well. So we'll come back to you with the open discussions as well, if there are questions which come up in the chat box or otherwise. Let me move on to the last panelists that we have for today. Welcome, Swati. Now, we just realized that you're part of that study which was carried out in Maharashtra, and you yourself are a nurse who's based in Mumbai. Now, these findings that you see in both the studies, how do you relate to reality, if at all there? The kind of reality that you witness on the ground in your area of work and otherwise in life. So it would be good to just listen in on your thoughts on this particular point as well. Thank you so much, Swati. Over to you.
Thank you, Dr. Dilip, and all the organizers for giving me this opportunity. I thank all the attendees also for giving their time and listening to our stories. Basically, COVID has really helped us to bring all our issues of last 40 years directly on the face of the people, directly on the face of the politicians, directly on the face of the bureaucrats. So I think that COVID is a lesson which will not go till we learn the lesson. So this is what I feel. And for nurses, I feel that there is nobody who is going to fight for you. It is individual nurses' battle who has to fight for her. So in my doctorate studies also, when I studied working conditions of nurses in public health hospitals, I was really shocked because I was working in private hospitals, and in one of the best private hospitals where we really never had problems related to the facilities. Okay, because it was a five-star hospital, so we never had issues related to the facilities. But definitely, I as a nurse had a lot of issues related to the management and the policies for the nurses, where I always felt somewhere, I was not at par with the doctors, and there was discrimination, there was stigmatization. We knew quite a lot about the patients, but there was no space for us. And if we would voice out related to the ratios and workload, we would be victimized also. So that actually led me to come out of nursing and get into a different profession, that is hospital administration. And where I realized that every nurse should envisage to become a hospital administrator or a leader, where she can control the administration and the policies and implement those policies for the nurses. And in the COVID times, that is what we saw, that because the nurses, the nursing leaders didn't have that much of control and power, because they were all reporting either in the public sector to the doctors who were the medical administrators, or in the private sectors to the CEOs who were the management and who were the part of management. And they were answerable for the bottom lines. At the end of the day, most of the private hospitals work on the bottom lines for the profits. Okay, so even if the nursing leader wanted to help the nurses, if she wanted to save her seat or her chair, she was not able to do it because she was on the side of the management. So all these, what you say, jigsaw, it is a jigsaw puzzle. Okay, so I feel somewhere that unfortunately in India, if you look at the history, nursing has come through the nursing education has come through regiments, okay, through army background. So we are always put with lot of lot of discipline, okay, and that is the culture what we have in India, that nurses cannot voice out. Second, again, the answer is because they are females. It is most of their bosses are males, and it is male dominated. So that is a gender bias again there. Third, if you see the organizational structure is such that they don't uh, allow them to get unionized. So you will not find any nurses joining a union or voicing out because she's scared of getting victimized. Okay, and it is not accepted at the hierarchy level or even in the syllabus. In our syllabus, we are not at all taught to form the unions. Okay, forming unions is bad. Joining union is bad. Voicing out your problems is bad. So all these things, you are breaking the nurses back in the school itself. Okay, so she doesn't know what is right, what is wrong, and poor thing is always vulnerable. And I think this is the answer to the cause of 40 years of our problems of nursing. And unfortunately, we never had any movement support. Like, we didn't had any support from the feminists or any researchers. So 40 years, we were under the carpet. So even the public health specialists never rose for nurses, or the policy holders never rose for nurses. Yes, there were many people who talked or spoke, like how we are talking today in the discussion, that these problems are there everywhere, and now it is global. Nursing strikes were not only India, but nursing strikes were global in the best of the best countries. So even if they had good policies, there were strikes. So now what answer we have from ILO and from WHO, I'm waiting.
Are you done?
Yes, currently that's what I have. My questions to you all.
Thank you so much. I think you were just bang on target, right on the money in terms of your thought process, very clear thinking, very precise, and what exactly we wanted to hear. And
25 years in the profession and at the leadership post.
No, it's really nice. It was very refreshing to hear your thoughts as well. And
Thank you.
Well, my only how I look at this is that maybe we need to take this discourse a few steps further and make it reach the inline beneficiaries, who are the nurses or the midwives in India. And I mean, end of the day, if they get even 3 things done out of their list of 10, I think we would have achieved something. And that's
Can I add one thing?
Yeah,
With
please.
my experience as an activist, because I'm a nurse activist fighting for nurses for past 2 years, wearing that cap, what I realized is that all the unions and the association, especially TNI, at the state level, they have to follow up their issues with the government day in, day out. They just cannot write a letter and forget it. Okay, they have to sit with the politicians, make goodwill with the politicians, and they have to sit with the politicians, follow it up till it is not implemented. And it can be done only through the unions, associations coming together as one body in each state. Only then it can be formed. Otherwise, it is not so easy. Next 40 years, we will see, 80 years will be there. There is no answer to this thing, because nursing is divided into various aspects. You have private nurses, you have public health. Public health is again divided into municipal corporations, state health bodies. Again, private is divided into charity hospitals, and now privatization is like a, what do you say, it's a monster. Okay, they just want to take up that 80% of share to 100%. Because now even public health is going to be privatized.
Yep.
So where will the nurses go?
Thank you. It was quite thought-provoking. I mean, all the panelists and the speakers have done a really fantastic job in putting across their thoughts. So we'll have to tweak a bit because we have about half an hour left, and this session has really, we're getting to encroaching on the next session. So while you can park your thoughts that you wanted to put across in the second round of interventions, but I would like to propose, and I would like to move on to the next session, where of course all of you will also get a chance to speak and discuss. And for this, the facilitator for this session is a very renowned public health person, and also who happens to be a very dear friend, Dr. Vandana Prasad. She's a public health specialist, the technical advisor for the Public Health Resource Network, and this particular study group which worked on the Nurses Speak in Delhi. And she's also one of the founder members of the Jan Swasthya Abhiyan. But before I ride off into the sunset, I have had about almost 30 years of experience working in the field at various levels with nurses, primary healthcare, tribal areas, and whole gamut. But all is not lost. In my opinion, even today, in many settings, the uniform of the nurses, the nursing uniform, still remains a symbol of pride and respect in the communities. And it offers them, in the most difficult of situations, say, for example, a sense of security, when they're walking the length and breadth of rural and tribal and the most difficult to access areas. So, well, I like to think positively, and I hope things do become better for them. And this is not sweeping the issues under the carpet, but yes, hope still is there. So I will pass it on to Dr. Vandana, who is there, and then she can take this forward. The floor is in your very able hands.
Thanks, Dilip, but I hope you're not riding off into any sunset. It's not sunset time, so please hang on. And I wasn't quite expecting this because I thought that the panelists might have another minute or two, so I'll try to get back to the panelists after we raise a few comments and questions from the floor. I also request the organizers to help with, in case it's possible, to demute some of the people that one could call upon upon, it would be nice. Otherwise, do let me know and I will just try to raise some points. But before inviting somebody to ask a question, there's some things that have been happening in the chat box and in the Q&A box that I think are very, very valuable. And I want to repeat those for the whole house. So some points that have been made in addition to the panel discussion that's been going on. For instance, I think this is Veena who raised a very important axis of discrimination in our country, which is caste, and neither study really found it. It's not as though it was actively ignored, but perhaps it was not also actively elicited. But I think that is one, because we're talking of health inequity, that is something in India to keep in mind also as a possible axis. And one of the presentations, we had 5 axes of health inequity mentioned, apart from the 4 in the first presentation. It was also rural and urban differences. And then Swati very ably provided to us the picture of the private sector being so very disparate, between the corporate hospitals. And our study does go into that, but we didn't have time to get into those nuances. But how a corporate hospital is not really the same private sector as a very small, husband and wife, mother and father, mom and dad, nursing home in a small town, or a single practitioner of the informal variety. So I think that, it's a very variegated private sector, and it's very complex arena. So I think these were some of the new issues that came up. I also want to point to the fact that we have participation from Philippines, from this journalist from Pakistan. We have had about 125 participants, with many flowing in and out as well. And that's a good sign of participation. There are also people here in the audience who have been fighting nurses issues for a very long time. So I would like to invite some of them to speak, and they've been fighting at policy level as well as elsewhere. So let me just cast an eye upon the chat box where people, the organizers might be helping me to put together certain questions and invite certain questions. So while they do that, may I request perhaps Leela Varki is well known in this sector as a nurse, as a very senior nurse herself, but also somebody who's been advising government and so on policy. So Leela, would you like to just make a few points about everything you've heard? Of course, it's not new. I think the ILO representatives bang on to say none of this is new. We also know that. But unfortunately, we have no other device except to keep going on and on saying the same things in various different ways, in various different contexts. Today, the context is the pandemic, which should have provided a much greater impetus to nursing. But unfortunately, in actual terms, it has really failed to do that. So Leela, can somebody unmute Leela? Is it going to be possible? Could an organizer just at least let me know if it's going to be possible?
It is possible. I'm just trying to identify her in the participants list.
Okay.
She's still
You're
there?
doing that,
Otherwise,
Susan?
I think Leela is not there in the list as of now.
Okay, she might have escaped. Is Biraj Kantishom there?
Yes.
Can she be demuted?
Yeah, I will do
Unmuted?
that.
Yeah.
I'll do that.
Biraj, would you be ready to please ask your question, and then maybe we can invite a few panelists to respond to that. So she says, yes, Biraj, are you there?
He was there.
So Lakshana has also asked a question. She asked a question earlier about maternity entitlements in childcare facilities for nurses, considering that majority of the nurses are women. And in any case, now childcare is being seen in an ungendered way. Yeah, Biraj, there you are. Yes, Biraj.
I had unmute. I think maybe he's in the office and there's a lot of thing going on.
All right. So anyway, let me ask the question on his behalf. Maybe this is not going to work like this. So Biraj basically says that nursing is one of the most aggressively hierarchical disciplines, and it has indirectly led to discrimination, power abuse, favoritism, vindictive steps. How are we looking at it? What is our vision in correcting it in the near future? Now, I think all the panelists have sort of addressed or acknowledge the fact that gender is a major issue in being able to achieve anything on the front of the working conditions for nurses. But how exactly do we break this now? I mean, like, do we have any specific answers as to what can be done? For instance, again, in the chat box, somebody made a very interesting comment about health and wellness centers. That was, again, I think, Sulakshana, that they are providing for, in some sense, nurse practitioners, that somewhere breaking the hierarchy of doctors versus nurses, at least one axis of inequity, by promoting nurses or allowing nurses to do a bit more of the doctoring. And this has been resisted very strongly by medical associations, and we know that, and we do feel that it's time. In midwifery, we have faced the same kind of struggle. So there have been these struggles. Maybe the panelists would like to respond to some of these. Leela would have also been able to respond to some of this, because she has been fighting on behalf of midwives and so on also. So would any of the panelists like to respond to this? Maybe just very quickly, each one of you, if you could be very, very brief and just respond. How do we break this hierarchy, the gender hierarchy within nursing? Do we have any specific ideas from maybe other countries or innovations that have happened elsewhere, good practices and so on? So, yes. So can we maybe in the same order as we had started, start with our friends from ILO, Christian and Anna?
Thank you very much for the question. So breaking the gender silos is not I'm afraid it's not a quick fix solution that we can offer, but we need a lot of mindset, and we need a lot of mindset not only with men, but also with women. And I found it very encouraging what our friend Swati said, saying, look, we have to come together. We have to come together. The more voices are found together and being brought together, the more power women have. And yeah, I think it's also taking the courage to speak up and stand up for your rights. And a precondition for that is also that you know about your rights. So don't wait for others to improve your situation. Take your own initiative and join others and work as groups together. Thank you.
Just to add to what Christian said, I agree. I mean, these sorts of gender hierarchies, they're typically not, they're deeply entrenched, and they're not necessarily quick fixes, but some of the things that spring to mind would be empowerment of women through greater participation in workers' organizations, in nurses associations, making your voices heard. It also may be something that takes time, but the louder the voice, the more the chance that that the officials will have to government officials will have to take notice and hear the demands being made. And for that, there is, of course, capacity building, so that there's not only training for women that are seeking to have this activist role, to make these demands, but also sensitization, information campaigns to sensitize the public more on the issues and the challenges being faced by nurses, particularly during COVID. The other thing is strategic litigation. You've already talked today about the impact of this decision. If the ruling of the court is not being implemented, perhaps more strategic litigation is called for. I mean, I guess that's my background as a trial attorney in civil rights in the United States in my past life. But I would just that in India, there was litigation that led to a Supreme Court decision that recognized the right of women not to be harassed at work. So if there are demands for equal pay, for career progression, other aspects of working conditions that are being denied, bringing complaints strategically is a good way to get some action. We've seen with
Thanks, Hannah. I think, sorry, I'll break in.
just
Yeah,
sorry,
complete
just
your
to
point.
say,
Yeah.
just to say, we've seen this year in the ILO, we've seen nurses organizations also bring complaints for not so much a remuneration, but poor working conditions during COVID, and also the lack of personal protective equipment and other aspects. So that is another avenue that would be open to a nursing association that could bring a complaint under ILO rules. I just wanted to mention that.
Thank you. So very specific grievance redressal methods. Somebody mentioned in that box, public interest litigation. If things are not getting implemented, certain other ideas in the chat box, and important points about a more larger communication to the larger public, to patients groups and so on the sensitization of these issues. So very important action points made by both of you. And we'll be coming to different sets of panelists, perhaps for different questions. So, but Jibin wanted to respond, and Jibin is a nurse and himself, and also part of nursing association. So please, Jibin, are you there, and are you unmuted to be able to speak up? It's a bit complicated in this.
Yes, ma'am. Thank you,
yes,
and
there you are,
very
Jibin,
good evening to everybody. And I think it's very informative session, and I see a lot of discussions happening, and the last discussion about gender. So I would like to add something in the gender. If you look at the hospital now, right now, all the nursing directors and the nursing heads are women. And now, even they're women, and majority of the nurses are females. I don't know why the government is trying to come up with a reservation, especially in aims, like 80-20, like 80% reservation for the females and just 20% for the men. And in Maharashtra, in recent recruitment rule, they have come up with 90% for the females and 10% for males. And if you look back, like in 2017, there was an recruitment rule happened in Madhya Pradesh for about 100% for females reservation. So how do we balance this scenario? Because looking at our profession, we have very few male nurses, and they are struggling to get job, first of all. And even if you look at the nursing education, we have very few limited seats for the men. And if you look at the defense area, men are not allowed to work as a nurse in defense. Then they're not entitled to get an admission in defense area. And the exploitation is largely increasing. And when we talk about the unions, we don't find any women participation in unions. You will find majority of the union activists are men in nursing. So my question is very simple: how do we balance this gender? Because we want both the gender to come up, and how do we support each other? This is one of my questions. And the main other few things are that, why don't we have a job description? I mean, we've been talking about the nursing for quite a bit of time, but we could not able to come up with a proper job description right now, because our nurses are doing pretty much job. I mean, even if you go to a hospital, you will find they're doing all nursing and non-nursing jobs.
Yes, yeah.
So it is not described at all. That is another issue.
So,
And why, yeah, please.
No, just make your point and then.
Yeah, and why can't we teach the nurses, during their college and school time? Why can't we teach them about the collective negotiations and collective bargaining? This is lacking in nursing. Why can't we groom them from the nursing studies itself? This is not happening in India, because if you look at the quality of nursing teachers in India, it's poor, I'll tell you. I could see many nursing schools do not have nursing faculties or do not have qualified people to train the nurses. Then you expect them to come up with a good quality is not possible at all.
Yes, thanks, Jibin. I think it's very interesting. I was about to say that do we go, because somebody mentioned the lack of women in nursing leadership and nursing associations. And I was pondering, about reservations, because that is a tactic that this country has used for various other communities that have been discriminated against. And our own study reflects upon the discrimination that male nurses seem to feel in the reservations that are happening for women nurses. Now, perhaps there's a halfway point to be had here about reservations in leadership capacities, whereas perhaps some softening of reservations in the general capacities, and where we know the study informs us that management prefers not to hire male nurses because they have a greater voice and they are better able to associate and associate with the unions. So that has come up as a finding in the study as well. It's a complex and question. Then where do we go from here? If we ask for more space for women, does that also reduce power? So I think collaboration and working together for men and women nurses is something that we'll have to work out, and what exactly would be the equation. Would Susanna or
I would like
Shweta
to
respond? Yes, please. Okay. Yes.
I would like to respond this question
Do
because
that.
yeah, we too felt that means 80-20 ratio and so many problems are coming up, and we received a lot of complaints from the nurses, and because in this regard, and TNAI has taken a resolution to fight. We will we are going to file a case in the Supreme Court about the male and female ratio of nursing to come up. And number one, as that means TNA has really realized that we all need to work together. And in February, we had a association with all the associations and federations and unions meeting. We held it in a TNA headquarters. Nearly 18 various associations and federations have joined together to fight against and many of the issues. And it started in Delhi. Now the Delhi chapter, Delhi TNA chapter, along with the unions and governments of the Delhi, they are divided and formed a committee, and they are working on all these issues one by one. I hope when we come together and join together and stay together, I hope in future we will be winning many of the issues. And
so Evelyn, would you have any answer to this? Like, we are saying women need more space, but we are also worried about this ratio that is being enforced for men to be kept out of the nursing profession. So what would be the answer? Have you come to some kind of conclusion? Or are you still deliberating on this issue?
No, we are planning to file a case in the Supreme Court about these issues.
No, so what would you like? Would you like this?
Yeah, there should be no parity, gender bias to be.
There should be no gender. Okay.
Yeah, because the admission time, they are not having any issues. They are not taking more of admission of the boys. But at the time of recruitment, they have a lot of rules and regulations. So we are working on that.
All right. Well, it's complex how we deal with the gender both ways. Right. Would Susanna or Shweta want to make some comments on some of the things that have been talked about already in terms of questions? One other point that Jibin made, I just want to reinforce, is the fact that nurses are being made to do all kinds of unskilled work. This point was also made in the Q&A box by an anonymous participant, and it did come up in the panel discussion also, that nurses are being misused as ward boys and ward women, and being made to do all kinds of work that is really not a nurse's task. I mean, it's really a wastage of their skills and their expertise. So that is also an issue that perhaps some of the panelists might like to respond to. So the presenters in the first session, would you like to say anything about that? Or any of the issues?
TNA prepared the job description for the various levels. And again, they submitted to the government to implement it in the uniformity across India. But still answer is waiting.
Yes, Evelyn, the whole issue seems to be one of implementation. So, how do we crack this, I think, is one of the questions that we need to talk about. So, yes, over to Shweta Marathe, Susanna, Ipsha.
I think maybe Susanna can go ahead with this question, because I have tried to answer some in the Q&A box itself. Yeah.
Thank you.
Susanna,
Thank you so much. Yeah. Susanna?
Thanks. I just wanted to go back to the question of Anna about the inspection of hospitals, and the fact that the inspection capacity of the government has been really reduced to the point that it's nearly inexistent, and that there is also an expectation from facilities, including hospitals, that if there is an expectation, if there is an inspection, they would get a call in advance to be informed of it. And I mean, I'm aware that those are against the ILO conventions on the issue, but that's actually the current situation here. And therefore, one of the reasons why, of course, implementation is lacking so much. The other point about the possibility to get access to labor laws, benefits under labor laws, it's very interesting that normally nurses would not come in the pool of workers that abide by the general benefits provided by general labor laws. But it is because their salaries are so low that they are within the threshold. There is a threshold by which, after which, when your salary is higher than a certain level, then you don't receive the benefits provided by the government. It's then a benefit that is provided by the employer as per its own way of organizing it. But in this situation, because nurses have such low levels of salaries, they are entitled to all these benefits. Now, even if they're entitled to them, then the question is, are they going to ask for them and are going to be able to fight for them? And again, it's a question of implementation. So we come back to the question of implementation back and again. There were points made about the fact that we have the recommendation of the Jagdish Prasad Committee. There is even recommendations that date back to 1999. Recommendations are available, but then what is the mechanism to ensure that they are implemented? And that's one of the other recommendations that we make in the study, that there needs to be an oversight system to ensure that the recommendations that have been made are actually implemented. And the last point was about this discussion about discrimination of male nurses. And I think we tend to speak about it as gender discrimination because we are talking of a cap on male nurses. But I think what came out of the study that is very interesting is how it's actually victimization of possible labor members. And it would be very interesting to hear from the ILO if there is a way that we could actually bring that up, because the feeling from the nurses was really that it's because men will join unions, they will become union members. So because of that, you don't want them to be in greater numbers. So it's not a question of gender, it's really a question of union victimization.
Right. So there were two raised hands, Varun Kakade and Sonali Durge. Is Varun Kakade here? Can he be unmuted to make his point or to ask his question? And then we'll invite some other panelists to respond perhaps.
I'm just working on it. Just give me.
All right, thanks. And Sonali Durge. Meanwhile, so, again, obviously there's a struggle on our hands when everybody knows the issues, and yet the movement on that is very slow, and the slow movement happens really as a result of quite a lot of confrontational work where, within the legal arena or otherwise. Strikes and so on are also not unknown in this country, and they are, much maligned, even though they take place after months and sometimes years of trying to negotiate for very basic things. I think that we do need to keep in mind structures, and some of the panelists have referred to them. So, to break through, you need devices and structures. It's one thing to make an environment where people would want to respond to nursing issues and be supportive. So supportive environment, very important, advocacy important, research important, but we also need facilitatory structures. And I think that Susanna mentioned that one of the recommendations of the study is precisely that as we have needed for other issues and areas which have been historically marginalized, you need a system and a structure, a body that is able to facilitate and push forward the kind of consistent follow-up that Swati was mentioning the unions need to make. Perhaps we need another party to be doing that. So that is one device. I also mentioned the nurse practitioner as a systemic structural device that could possibly break hierarchical barriers. Yes, so do we now have, I was kind of filling in the gaps while we were trying to get to Varun Kakade. Is he there? Or to Sonali Durge? Either of them accessible?
Varun, if you're still there, please go ahead and speak out.
Yes, Swati, I see your hand up and I will invite you in a minute. Or else please type into your chat box so that we can at least bring up your point if you're having difficulty coming through. So let the team continue to work on trying to get these people who have raised their hands to be heard. Meanwhile, let me invite Swati. Yeah.
Thank you, Vandana. I thank actually Suzanne to make that recommendation of facilitatory structure, because I think that is missing everywhere, and somewhere, nurses in the history have never come out of their offices or of their clinical hospitals, okay, to directly go and talk with the officials related to their rights, because it was never needed to them. If you see 30 years back, okay, because everything was so crystal clear, and there were not so much of increase in their work, or so much of changes were not there. But in past 20 years, if you see, there is a sudden change in the health of the health sector itself, and the changes in the disease conditions also. So somewhere I feel what Jibin rightly said, that we have to groom nurses during their college or their education time, and tell them how to fight their own battles. So that will be one of the most important thing. Secondly, I feel that associations like TNAI are at every level, at city level, at state level, at national level, and I feel that they have to really form these facilitatory structures, because they know how to do it, because they have more than 5 lakh people with them who are their members, and it is the oldest organization, and it has a strong say, okay, because the same thing had happened also when we had the bill, the nursing bill, which is there, okay, which many of us were not even aware about this bill. So if you see the overall communication with the nurses by the state or by the center is so poor. There is no facilitatory mechanism itself. All the things are done on WhatsApp. So that was the special thing which I came to know. How can WhatsApp be an official thing? So I feel that I feel TNAI has that bandwidth and capacity to bring all these issues together, and with the other unions fight for it. And litigation is the key. There is no other answer. And second is media, because during COVID, I think media has helped at least Maharashtra a lot to bring changes in a lot of issues which the nurses were facing.
Yes.
So I think these two things we can definitely do. Thank you.
Yeah, good point, Swati. And reinforcing what other panelists have also been saying about communication being so critical, mass awareness on these issues, and a systemic approach. So Lakshana is making an interesting point about solidarity across cadres of women workers in health and even otherwise, I would say, but in health in particular. For example, we have the Anganwadi worker is the workers, they've been workers for 45 years, over 45 years, and still not considered workers, still considered honorary workers. They do a lot of our health work, public health work in particular, immunization and so on, facilitating of nutritional services, public health nutrition, and maternal and child health. And they're located in the Integrated Child Development Services Scheme, somebody was asking, as well as the ASHA, which is a community health worker, again, not as old as the Anganwadi worker, but again, not considered a worker, not given a salary, no dignity of work whatsoever, and piled with every possible piece of work at the community level in rural areas in particular. So building solidarities between all these cadres who are similarly struggling, and they are unionized separately. But where would be the place to bring them together, and who would really have the bandwidth to basically create those solidarities is question comes up, but it's an important and interesting point. I'm not sure if we've still been able to get those people to unmute themselves.
I tried something else. I added one of them as a panelist to see if we can hear them.
Okay.
Varun, if you can still hear me, he's my colleague.
Varun seems to be there. Yes, he is there now, visible.
Maharashtra, Pune right now as part of our health systems team, earlier in Bastar in Chhattisgarh.
And this might be our last.
Yeah. Varun, you're the last one whom we'll be hearing to. So if you can just speak if you want to.
Yes, Varun. And of course, we have the women at home who are belong to the unpaid care work economy. And I'm so glad to hear from ILO that there is going to be greater focus. Varun, I'm only just waiting for you.
Maybe
Not going to happen.
not.
She's also here amongst the panelists. If she could unmute herself.
Who?
Sonali Durge, the other.
She's also there, but they somehow, for some reason, they're not being unmuted.
Like it's from their end. They have to.
Sonali, would you just be able to unmute yourself, please? Sonali and Varun. You can see there's a mute button, no? The red button, just left-hand corner of your screen.
Jammu Anand also has his hand up in case.
Who's that?
Jammu Anand is the president of the.
Sorry, I can't hear you well, Susanna.
Jammu Anand, the Nagpur Municipal Workers Union.
Yes, so if you could type in his comment, because we're having this difficulty of getting people to unmute. Or is it possible to unmute him, in which case he may go?
Hello?
Yes, yeah.
Am I
Anand,
audible?
yes, yes,
Yeah.
Anand, you're audible. Please go ahead. Briefly. Yeah.
I'm the president for Nagpur Municipal Corporation Employees Union and is an affiliate of PSI. During COVID first phase, we could organize the contractual health workers under, a national health mission. Those who are working under urban primary health centers of my city. Yes, quite interesting to understand, know the health workers and particularly nurses in private sector. But there is another sector which is coming up, that is contractual health workers within the public health system. And here the burden of, public health or the municipal health is additionally shared by these contractual health workers, because all the municipal corporations, at least in my municipal corporation, these nurses posts are vacant. Hence, during COVID, the municipal hospitals are not in a position to really serve the society. So the whole burden of public hospitals added with the UPSCs, but the conditions of the nurses are very bad, in a sense they are so overloaded, their honorarium is very less, and at least in the state government, the nurses unions are heard, even while taking new steps by the commissioners or the health directors. But in this case, I see absolutely they are now reduced to some bonded labors.
Yes,
So this
Anand.
is one,
Yeah, I think
this
a
is one
very important point of contractual employment within the health sector all across the board. We know even amongst doctors, there's huge discrimination between the contractual and regular, and among nurses, amongst all categories of health workers. So a very, very important point of informalization of the formal economy that's going on steadily along with the privatization. So I think we're at 5:30, but Anthony, would you like to just very briefly make one remark? This will have to be very brief, of course, because we are running now to closing times. Yeah. Anthony?
Hello.
Yes.
I wanted
Anthony,
only
speak,
to,
yeah.
can you
Yeah.
hear me?
Yes, we can all
Good
hear you.
evening.
Please go ahead. Yeah.
This is Dr. Anthony from Cochin speaking. I only wanted to listen to the women, especially the nurses. Did not want to say, but as a parting, a few tips with all solidarity towards improving nursing's plight is, one is keep your autonomy with regard to your matters at directorate level, especially government. Let the nursing council or equivalent to that, whatever the body is, don't allow the men to interfere with, and have directly reporting to the principal secretary of health. Get that established. Another low hanging fruit is, whichever states in organized fashion, nurses have attained certain negotiated salary minimum, basic minimum, make sure that it is implemented. Many managements have gone back on it, and if it is there, complain to the labor commissioners and get it enforced. If not, go for a public interest litigation. Courts are one opportunity you can really get things done in this country. So go to the court. Third
Right.
thing is nurses' involvement jointly as a group in the PIP project implementation plan for every year's annual budget allocation for the National Health Mission. Get involved in that, make your cases, whatever your demands, earmark, work out budget and demand that budget. There is no way they can deny when it is genuine needs. Wherever, with regard to the private sector, whichever NABH accredited or ISO certified private hospitals, if they are showing discriminatory salary, inadequate nurses, physical facilities, get, even if they manage certification, give confidential report to them, things are not working as it is. Such feedback to them, they will come for re-inspection and get them disqualified. A couple of instances like median.
Right, Anthony. I'll have to ask you to, yeah. So 3 very
last
important
one,
suggestions.
I would
Yes,
say
all
the
right.
beautiful last one is that
Yes.
the Health and Wellness Center is a fantastic opportunity National Health Mission has provided you.
Yes.
What a nurse can do it. And I've witnessed in Bishnupur district in Manipur and Chindwara district in Madhya Pradesh, I was asked by government of India to go on inspection. And I found what these young budding nurses as a community health officer does it in health and wellness centers. It is immensely changed the appeal and people's confidence in those health and wellness centers. So this is a beautiful opportunity to show what a nurse can do. Thank you.
Thanks, Anthony. I think, a lot of action points have been made, which are very specific, very helpful, and we will do our best to collate these and to send them out as an organizing group to the people who have participated in today's meeting. As we draw to a close, there are just a couple of final points that I'd like to make in closing. Firstly, it's evident that we need much longer time to be discussing these issues. I mean, it's very clear that we're all really keen to be engaging, discussing, and debating, and we need much more such opportunities. And I think that the organizers must continue to provide platforms for this kind of discussion to keep happening. And I think the final point is that, we have to locate the nursing struggle within the larger issues that are confronting the health systems, which is the lack of investment on the whole. I mean, how can we provide for better working conditions without money? Is it possible in a healthcare system? What is the current level of investment this country is making to the health system? Still running around 1% of the GDP, current budget, any previous budget, it's the same old story. So I think to locate it in the larger battles, this is one larger battle, that much larger investments are needed in the system on the whole. Then much larger investment is needed in the public health system. Again and again, evidence is showing us that we need a public health system for health in our country. And this juggernaut of privatization, of profit making in health, how can how can profit making in health go hand in hand with providing better working conditions for nurses? Is it possible? It's a contradiction in terms. How can you make more and more profits if you, unless you keep salaries low, unless you exploit and so on and so forth? Exploit also patients. So it is patients being exploited. It's also health workforce being exploited. It's not doing any good to anybody, because the sicker you are, the more money somebody is making out of you, really. So I think that this whole system has to be challenged. The nursing struggles, and I would request all the associations to put, to really basically position their struggles alongside the other struggles that are happening in the health system. We must save the system on the whole. We must save the public health system. We must demand better investments in the public health systems. Only then we will get our due as nursing cadres, doctors even, and patients, and the community's public health will improve. So I think that with those final comments, I thank on behalf of all the organizers, a very, very fruitful and rich discussion. This is the second in this particular series, but we hope that we will be doing many more. I'm sorry that we were not able to give more time to all presenters and panelists, and we had to frequently kind of step in and abort very meaningful kind of discussions, because everybody needed to be given time and space to speak. And sorry for the technical kind of problems that are inherent in Zoom meetings. But nevertheless, I think we will all agree that it's been rich and important, and that the action points that have developed will be collated, and the studies will also be circulated, and we shall hopefully meet again. So if we can get our videos to go on, and perhaps we may now all speak together and wave to everybody, including the participants. And thank you so much again. Very sorry if anybody was left out and not given enough opportunity to say what they were burning to say. But we shall meet again. So, bye-bye.
Bye-bye. Thank you so much.
Dilip, anything closing end with?
Maybe just I'll just pick on what you said in the end on this investment in health workforce and nursing. We had commissioned one study earlier, basically talking about why we need to invest in health workforce in India, and where and in what areas. And the second study has just been completed, final draft, and this talks about how much to invest, where to invest, and why. So these are two very interesting pieces which have come out and which will come out very soon, and maybe the participants should watch this space, and we would definitely like to have a similar one once everything is in place. And it also talks about a lot on the nursing numbers and the problems, issues, and also the need for investment in that. Those are my closing remarks. Please watch out for this space. Please come back, join us for more interesting discourses on health workforce and nursing. Thank you so much. Thank you.
Yeah, everybody can speak simultaneously. So, yes. Bye-bye.
Thank you.
Bye.
Thank you so much.
Bye, everyone.
Bye-bye. Thank you.
Bye.
Thank you.
Goodbye.
Bye.